what I wanted us to be able to do now was, in the morning we spoke about some of those big population mental health issues. What can we be doing to make more resilient communities? What should we be doing about screen time in kids? And at Black Dog Institute, we have two areas of focus. One is that population mental health. The other is clinical care for people with depression, anxiety, or post-traumatic stress disorder. And so what I wanted to do in this session was for us to move to think more about the role that digital can play in treatment. And this particular panel is looking at blended care. How can we combine human and digital approaches in clinical care? And leading this discussion, we've got Dr. Melissa Black. Mel is a clinical psychologist. She's a researcher at the Black Dog Institute. A lot of her research focuses on these new models of care, but also puts that into practice. And Mel's played a key role in some of those digitally enhanced services that are offered for healthcare providers and for emergency service workers. So that may come up in the discussion. But joining Mel, we have Emily Harper. Emily is the Assistant Secretary for Digital Mental Health and System Navigations Branch. So she has the unenviable task of overseeing the development of digital mental health policy and trying to reduce fragmentation in the digital mental health ecosystem in Australia. So if it doesn't work, it's all your fault. We also have Karen Spellman. Dr. Spellman is a GP, worked in inner Sydney for 25 odd years, I believe, and is also the primary care mental health advisor for the Inside Out Institute at the University of Sydney. And then rounding out the panel, we have Mark Nevin. Mark's the interim CEO of the Australasian Institute of Digital Health. So that institute looks towards enabling digitally healthier lives for all. But he's also held a range of other leadership positions, both around government affairs, workforce development, policy, strategy. So you can see we were particularly pleased when we were able to pull this panel together. So thank you all for being part of it. Mel, I'll hand over to you. But everyone, just remember your phone, and as you're listening, start putting the questions in and start voting on them.
Thanks very much, Sam. So I'll just set the scene a little before we launch into the discussion. So we've heard a lot this morning about the potential of digital technologies to improve mental health. And just to give some stats that are noted in the discussion paper around the mental health treatment gap. So of those who need mental health care, only about half of those who need it access it. And of those who access mental health care, only about 14% receive a full dose of an evidence-based intervention. So we have a long way to go in actually meeting that need, and meeting that need in a way that actually treats people's mental health problems. In terms of the workforce, and I've just focused on psychologists here, that's where a lot of the Medicare funding is, but 3 out of 4 psychologists have a wait list, and 1 out of 3 have closed their books. When I'm doing intake in our clinic and I let people know who've reached out for help now that we've got a 3 to 4 month waiting list, having that conversation is really difficult, problem solving with them, talking to them about digital programs, and they go, yes, I've tried that, but actually I really just need to speak to someone. And so thinking creatively about how we can better do that. So when we talk about blended care, we're talking about the combination of the digital components, which can provide education, skills development, assessment, progress tracking, somewhat in a cookie cutter model, but we're doing some really good work to try and tailor those programs. And combining that with person-to-person services. So this could be telehealth, video conferencing, telephone, or in-person services to provide that intervention to help boost engagement, to work through more complex or chronic problems that aren't addressed by digital, and to do a deeper dive into problems that might be better suited to talking through with a clinician. And there's a health economic argument here that potentially clinicians could see 4 to 10 times as many people with a blended care model compared to just a face-to-face. Talk very briefly about TEN, which is the essential network, a blended healthcare service for health professionals. And this combines a self-guided digital mental health checkup, evidence-based tools and resources that have been developed in collaboration with our partners, digital mental health programs, so with our partners at This Way Up from St Vincent's, looking at CBT programs, and a tailored navigating burnout program for healthcare workers. And then access to that one-to-one support. So whether that's peer support through our partners at Hand in Hand or clinical care. So Kathy Hutz here from Doctors Health Advisory, they're one of our partners. Black Dog Institute Clinical Services, as well as leading through to the Australian Psychological Society, Australian Clinical Psychology Association, and the Royal Australian New Zealand College of Psychiatrists. So that sets the scene a little for what we're talking about today. We've got plenty of burning questions, but of course we've got a poll first, so please join the QR code. So the question is, if you or someone you care about needed mental health care, who or what would you like to deliver that care? Maybe a leading question heading into a blended care panel.
I feel like there's a right answer.
So we can probably call this one pretty early, you know, and it is a leading question. But that mix of digital and face-to-face. But there is that 19-20% who would still prefer to see a clinician face-to-face. And I think we'll get into the nuances of that in our discussion, that there is a role to play in that, and how do we also provide digital services, or maybe it's not appropriate for those people. So I'm really keen to launch into the discussion. So let's start with each of your views on what you think the role is of digital in closing the mental health gap and how it could be better integrated into the mental health system. Karen, maybe I'll start with you first on the ground GP.
Oh, thank you. It's working. Fantastic. I'd like to put in a plug for the role of the GP in mental health, because we do often get left off the list. I don't have the stats at my fingertips, but if you do look at how much mental health care GPs deliver, it's probably more than psychologists and psychiatrists put together. Certainly funding-wise, it may be psychologists that have a bigger slice of the funding, but we do the vast majority of early intervention, assessment, and we need a system that supports us to do that. So I think digital has a really big part to play in that. We are really well trained. Talking to Charlotte from the College of GPs, we have a wonderful training program. We come out able to manage whole person care. It's the system that really hamstrings us. Hamstrings, is that a word? And so the system can support a better delivery of care in community. When we represent our communities, we're often of our communities, we are across the country. And so using digital to support us, I think, is a really important thing. And I know there's many different ways to do that. In my role as Inside Out GP advisor, I'm helping to create some really wonderful resources for GPs at point of care. Once they've raised the question, this is particularly in eating disorders, but it, equally can relate to other mental health conditions, and having digital support at point of care, I think, will really help to reduce the burden on specialist services. Not that we're not specialists, but you know what I mean. So I think that's where I see the biggest role for digital.
Yeah, you raised some really good points about whole person care, and Mark, I know, has some perspectives on that, working across the health space. So interested in your thoughts, Mark, on this question.
Thank you, and thank you to the Black Dog Institute for addressing this really important point and for assembling this great group of people today. I guess, Mel, you touched on this in the introductory comments around the need to do things differently as well. We've got workforce shortages, we've got people on waiting lists, etc. We need to look at how we can, I guess, leverage the capabilities that we have and the resources that we have to be able to deliver care in new ways and deliver care in ways that will reach vulnerable communities and reach people in regional and rural areas where access to care is much more challenging. I guess I'm a big proponent of the digital health community. I represent the digital health community, but I think it's really important to learn from the examples elsewhere whereby digital health has gone really well and gone badly as well, and to learn from some of the key learnings from that. And for me, some of those relate to the importance of taking a human-centered approach, so particularly looking at the clinician and the consumer and how they're supported to change how care is delivered across these new platforms.
Yeah, great. No, and I think we'll pick up on many of those points later. And Emily, from your role, and you've also worked in other health implementation roles, so interested in your perspective.
Yeah, look, I think we heard this morning from Assistant Minister McBride around the sort of focus on access and equity. So I think a lot of what I see digital being able to offer is to really enhance access and equity to those who may not be able to access any other services, but also taking that slightly different lens around wellbeing and protection of wellbeing and early intervention as well, rather than looking to, I think, completely focus what are very finite resources, and everyone in the room knows this far better than I, on the very acute end. So we really do need to focus more, I think, on stopping people, or addressing their needs early in the course of their illness, or when they are becoming distressed, to prevent them from becoming more severe, because we do know that once down that path, it is far more challenging and resource intensive to return those people to their sort of optimal functioning. So I see a really huge role for digital in this space, and particularly taking into account, I think, Mark, you mentioned the workforce challenges as well. The reality is that the demand does far outstrip the supply in terms of our health professionals. So we do need to make, I think, better use of the resources we have, and I think, digital done well has a lot to offer in that space.
Yeah, I'm just seeing a question come through in the chat, and it's probably a helpful time to bring it up, is, can digital products really help those who are really unwell? You've spoken about, early in that point of, in that care pathway, the question also says, aren't they just for the worried well? But I'm interested in your thoughts, from a health systems perspective as well. How can we harness technology to help people at that more acute or severe end?
Perhaps that's about supporting clinicians as well, providing easy access to resources, and empowering consumers and carers to access those resources to support. I mean, when we are at the pointy end, often we're dealing with complex comorbidity and system issues, and so being able to resource people around the person at the focus will presumably be an effective way of taking pressure off as well.
Yeah, that picks up on some really nice ideas from both of this morning's panels around empowering communities and empowering families, that we don't just want to focus on the individual. So yeah. Emily, do you have some thoughts on that?
So the question around the system more generally?
The system, and also that more acute and severe end.
Yeah, I think, look, we do know that there are some digital courses, digital treatment programs that are evidence-based, and there is a strong evidence base for them, but at different levels, I think, and that need for still engagement from a clinician, be it a general practitioner or other, remains really key. But I do think, whether or not it's just the worried well, I don't think it is necessarily the worried well. I think we do see that there are a range of programs and initiatives and resources that are out there that people greatly value. I do really want to understand and hear from thoughts from colleagues here as well about what we can do to enhance the trust in some of these digital resources, both from a clinical perspective, and some of that's about knowledge and so on, but it goes down to the evidence base, the measurement of outcomes and so on. But also, I think, public expectation. I think that issue around, if I front up to my GP with a mental health concern, I think at the moment my expectation is that I would be referred to speak to someone, be that a psychologist, a mental health nurse, or whatever, most likely a psychologist. And we don't want to see digital as being somehow lesser than in that pathway, when it might actually lead to a better outcome in the individual circumstances. So that's something I'm really keen to unpack and think about more.
Yeah.
Just to build on the points that were made, the upskilling of the clinical workforce is really important around how to engage with digital tools, and that's really a macro thing as well, to think about how we can provide kind of training pathways and guidance for clinicians, because clinicians are often the individuals that are, I guess, imparting the information to the health consumer as well, and they're a trusted source of information for that consumer. So I think that clinical workforce upskilling around digital readiness and supporting them to manage the changing way that they will practice through digital technologies. For other areas of healthcare, the really complicated parts of digital health adoption to manage are when you change or interrupt the clinical workflow as well. That's when you really encounter like resistance from the clinical users around that. So it's really important when you are adopting those digital technologies that it's clinically led and there's an engagement with the clinical team, input from consumers as well early on to help to support like managing that change. On the second point around people becoming acutely unwell, I think it's really important to identify when you are delivering care in a hybrid blended way, that you need to identify that the individual symptoms may worsen quite rapidly and you don't have the same visibility of that as you would have for an in-person care. So there's a lot of kind of guidance and standards around this, some of which have been produced by the Medical Council of New Zealand has got very good standards in this respect, and the Medical Board of Australia has recently updated theirs so that clinicians should know what signs are to look out for where symptoms are deteriorating, and the person should be brought in for an in-person consultation.
Yeah, no, that's really helpful, and I don't want to steal the next panel's thunder, but I know, Mark, you have some thoughts on AI and the potential role it can play in that dynamic space. Do you want to share some thoughts around that?
Sure. AI has got phenomenal potential in this respect for a variety of different ways. Firstly, to help kind of monitor the well-being of populations, but those tools need to be developed in a way that's ethical as well, and in a way that, I guess, where somebody's well-being deteriorates, then the AI tool will signpost that individual to a human being as well. And if you're using AI within clinical care, it's particularly important to have human oversight of how that is deployed and ensure that it's done in a way that's ethical, respects the privacy of individuals' preferences as well, for instance. So yeah, happy to talk more about that later.
Yeah, I think that leads really nicely into our next question. You touched on this, Emily, around trust and uptake, and upskilling the clinician workforce is one of them. But maybe I'll go to you, Karen. What do you think would increase both clinician and consumer trust in digital products and alongside person-to-person care?
Well, excuse me, I think the clinician has that relationship of trust, and as a GP, I speak really strongly for that relationship that I have over generations and decades with my patients, and I know that they trust me, and so that they will trust something that I recommend. So I think it's a big role of places like Black Dog and Inside Out and Headspace, who have that brand of trust as well, and who have the funding to do the research and to digest things for us, like Jan Orman's work that she does with the GP community, helping us to work out which are the good apps and which are the not good apps, and how to work that into our clinical workflow. So we have the individual trust, and we rely on the system to help give us the information. And I guess maybe this is a good point to mention that one of the things that I'm working on, which is the Inside Out GP Hub, which is placed at point of care, and is something that can be agilely changed to meet the need of the consumer, the doctor, the system, like at every different point of care. It's not just here's one particular app or one particular product. It's actually working within the system in a really therapeutic relationship to deliver the best care possible.
Yeah, and maybe I'll ask you a clinical question. If someone's skeptical about digital programs but you're recommending one, what tend to be your go-to strategies to help let them know that it is safe and effective?
Well, a lot of people are skeptical, and even the people who aren't skeptical, again, I'm not a researcher in that space. I can't tell you the exact numbers, but clinically what I see is the uptake is actually pretty low, even with highly, beautifully researched and evidence-based. I won't name names, but it's actually really difficult to recommend programs and to have somebody see it all the way through. So what I would often do is start that off in the consultation, and I'm showing them this is how it's been used before. Come back and talk to me about it. It becomes part of the therapeutic intervention, and I believe that's probably the best possible way. But it's still hard.
Yeah, Mark.
Could I please answer that? Because my organisation, under a grant from the Department of Health and Aged Care, is doing a mobile health assessment framework as well. So some mobile some mobile health technology and digital health technologies are regulated by the TGA under a category called software as a medical device, but there are quite a few that are not as well, which still have can be recommended or prescribed by a clinician for an individual. And we're leading a piece of work with several universities with expertise in digital health around how you can get some guidance to advise on the mobile health app developers around what are the expectations in a healthcare context, because a lot of the developers don't come from a healthcare background, around the expectations around having input from clinicians around the design of those, thinking about the consumer journey right the way through, and the risks that the individual may have as they're working, engaging with a mobile health app. And the intent of that is to help guide state governments and providers in respect of like mobile health apps that they might deploy or prescribe within their health settings. So we hope to have that out soon.
Great. And Emily, could you say a little bit more around, and from working on other programs as well, what might increase uptake, particularly from clinicians, but in implementing the programs, what might help?
I think it's a really tricky one. I think there does need to be, it's education a little as well. I mean, not everyone is entirely familiar with what's out there. I think there are a plethora of resources as well at the moment, of varying quality and with varying evidence base. And certainly there's a role, I know, for government in assisting with that, but there's also a role, I'm sure, for everyone in this room and community more broadly to assist with the curation of resources out there. But I think it's public education in this space as well. If we think about, I sort of go back to sort of some of my earlier public health days. If you think about sort of people with a cold a little while ago, I'm sure you've experienced this all the time, Karen. Go in with a snotty nose to a GP, and the expectation was that you're probably going to get antibiotics for a period of time. And there were a lot of people, like patients who would walk in and almost demand that from their GP. It was a really strong expectation. It's very hard to say no to. That has changed a lot. It hasn't changed the whole way, but it has changed quite a bit, and the discourse around that and the public awareness around the fact that, look, viruses probably actually don't respond well to antibiotics. Just the awareness that, look, there are some of these things, there are some digital programs that actually work better in the right circumstance than perhaps being on a waiting list and not seeing someone for a period of time. Or perhaps this can help maintain you between appointments. And perhaps, you're having a difficult sort of, moment in time experience. Maybe you've had a bereavement, maybe you've, had a relationship breakdown. Perhaps there are things that are more time or focused, time limited issues that we all need support with at a particular point. So I think there's a lot of public education as well as education within, clinician spheres as well. So it's awareness, but it's also education, and it picks up on all of those themes about sort of interrogating, I think, the evidence base and again, some of those preconceived ideals that simply because you're not talking to a psychologist does not mean that you're not receiving the level of care that you need or that is best for you in that circumstance.
Yeah, doesn't need to be an either or. There's a question that's climbing the leaderboard, which I think might be really useful to go to at this point, and it's, what do you think stops Australian clinicians from using blended care? Is it the lack of knowledge, which we've talked about a little bit, that their patients don't want? Or I think this part we haven't touched on yet, that there are no MBS rebates. There's the financial reality. I know as a clinician, any other clinician in the room will know the unpaid work that happens. What do you think there's a role there, in removing that barrier?
Don't talk to me about item numbers, please. I don't think that, personally I don't think that's a big barrier, because we work with what's in front of us, and it's a time-based thing, right? So if I'm managing somebody with an eating disorder or who has concerns around mental health issues, I'm going to do that in the best way possible, and then I'll think about the item number later, right? I'm not going to not do it because I don't have the right item number. Yeah. So it's a little bit of a perverse incentive, I think. if you get me started about system reform, but I don't think a new item number fixes everything. I think we know that GPs do the bulk of mental health, but you guys don't know that because we don't use the right item numbers because they're paid less than the other item numbers, and it doesn't make a lot of sense for us to do that. I mean, there's not a lot in it, but philosophically, why would I do that when I'm also managing the whole person? So it's not just about using, don't start me. Sorry, but no, I don't think another item number is the answer for that. No, I think education, having time. I'm so grateful for the level E's that are about to come in November. Thank you so much. If anybody had anything to do with that, really, really grateful. I think that's going to make the world of difference to mental health as well, for whole person care to have that time recognised, and for our patients to be able to access those rebates and to show slow medicine. Let's take some time. Let's actually look at the social determinants. Let's understand, let's intervene early. That's going to make the world of difference. So I'll take it back. I do like that item number.
Yeah, it's a smaller number of item numbers, but more useful. Mark, do you have thoughts on that?
I'm forever in awe of GPs and how you manage to look after people so holistically within funding constraints. I'm a big proponent of clinical governance as well around supporting adoption and using that as a mechanism to manage the change with the clinical workforce. So thinking holistically around the standards, the guidance, the regulation, what upskilling people need to have, what are the quality assurance and safety mechanisms that you might put in place when you're deploying new technologies into clinical care, leveraging those clinical governance tools. And a lot of people do clinical governance without actually realising that they're doing that as well, around adherence to standards, reading guidelines as well, and then deploying those actively in your practice. I think that's a really, really powerful tool as well to support adoption of new technologies.
Yeah. And maybe on a similar issue, and I think Clinton put it really nicely this morning, that we might have mental health workforce shortages, but we don't have a shortage of human beings. And so having that connection. So, of course, there's the role of the clinician workforce, but how do you see the role? And the questions come through around, upskilling peers or people with lived experience to deliver blended care models, people in community. It's kind of somewhere in between the consumer or the people around the consumer as well as clinicians.
Bring it on. Absolutely. I think it's a really fantastic thing to enhance our armamentarium with. Absolutely, we need to improve the accessibility to consumers of that workforce. It can only help us. Absolutely.
Yeah, and then I guess there's the clinical governance side of things, and I guess that comes to the next question around the role of government and industry in assuring the quality and safety of digital mental health products and within blended care models as well. I might go to you first, Emily, on your role and what you think the government needs to do.
Clearly I think there's a strong role for government in matters of regulation often, and this would be no exception. So we do obviously have the digital mental health standards that have been released. I think it would be, there's lots of things as a public servant I'm probably not able to say or commit government to today, but I think, as much as I might like to, I think one thing I'm reasonably confident in saying is that there is a very strong commitment to those standards and to ensuring compliance with those standards in a timely fashion. And I would expect that to be adopted widely by not just the Commonwealth Government but by others. And I think that goes also, Mark, in part to your sort of conversation around clinical governance, other sorts of governance as an incentive to change practice or enhance practice, and just ensuring quality and safety is paramount amongst all of these things, and particularly the security of information as well. Recognising the sensitivity in this space, and it's not new. And I think Karen, as you reflected before, one of the things I'm really acutely aware of is the need to work really closely with colleagues across the department on some of these things, because it's very rare that an individual presents solely with one issue, and we tend to treat very condition-based, and we need to look at that whole person and the chronic conditions that they may be experiencing, and I think taking a public health lens at a population level, but an individual lens when it's appropriate, is what we need to continue to do.
I might just build on the standards comment. So I'm delighted that the government's now moving towards mandating technical standards around information sharing, based on FHIR, but also around standardized clinical terminology, so that when there's an output from one piece of technology, that can be recognized in a format that they can just open the files and absorb the information and data into the relevant part of the electronic health record. So I'm a major proponent of that. Last week I was with the Australian Digital Health Agency's Council for Connected Care, and we were having a workshop looking at, I guess, the refresh of the National Digital Health Strategy and what next in terms of like interoperability, and standards has a critical role around that. But one of the key takeaways that we had, if you can get it right at transitions of care, that's the point you really need to crack, where an individual moves from hospital to the community, or the juncture between public and private, or moving from healthcare to aged care, disabled care services, and the really importance of getting timely access to clinical information when an individual on the care pathway is transitioning from hospital to the community is of paramount importance.
Yeah, absolutely. And we were talking about it a little bit this morning of how that information can best be managed, how people can be confident that their information is kept private. And I'm interested in all of your thoughts on the role of the consumer in that. And of course, there are some points where people are very unwell or don't have the cognitive capacity to be able to do that. But there are many cases where the consumer could be at the centre and actually choose who that information is shared with. I'm interested in how you might see that working. We'll go to you first, Mark.
Sure. I guess I'm a big advocate as well for consumers being in control of information that's about them and being empowered to make decisions around how that information would be shared. This is not easy to get right, particularly when somebody's data is held across multiple different systems. The ideal that we would have is a tiered and a dynamic consent model, whereby tiered meaning that you can opt into your information or data being shared across a menu of different options, and then dynamic, whereby you may change your mind over time that you no longer want your data to be shared, or you want to opt in to have your data shared. There's a big debate around this with the rollout of My Health Record a number of years ago. I think the reticence to share data for clinical purposes has lessened a bit since we rolled out My Health Record initially, but it's still really important to empower the consumer and explain to them the benefits of why the information should be shared across systems. But technically, it's not easy to do that.
Karen, and thinking about the role of the consumer and improving continuity of care.
Oh, I think it's so challenging. I don't have any answers for this one, except to say that it needs to be better, and there's so much harm caused when communication doesn't go in the right way. And you know, I've been talking to colleagues this morning about examples of when it just goes so horribly wrong, and there's real harms done, as everybody knows. So again, I think trust with individual clinicians is really important, and you know, I'm not doing a paid ad, I promise, for GPs, but you know, we are the glue in the system, and we do hold a lot of that you know, concierge kind of role in the system. So if we can be part of that solution as well, rather than add it on. We were talking about the hospital systems, you know, which have changed from the paper charts on the end of the bed in my day, but yeah, it's fantastic to hear that there's better systems there. But we have terrific systems, but they don't talk to anybody else. You know, we have 16 different templates for referrals, and they get knocked back because they don't have the right signatures, and just does your head in. Honestly, it's really, please. I mean, the consumer is absolutely key to that, and again, just being able to hold that, be empowered to have the information go where it is useful for them would be fantastic. Yeah.
And Emily, your thoughts?
I think one of the things I've actually had feedback on in other roles as well as this one is the reflection on the expectation. There is actually an expectation that these data are being shared. And when they're not, it's really frustrating for the individual. So yes, there are people who are very sort of risk averse and very protective of their own data, but there's actually a very substantial cohort that just expect it to happen, and when it doesn't and they have to answer the question 50 times in different ways and so on, then they, you know, get understandably pretty frustrated. So I do wonder if there's a way in which we're able to leverage that cohort as well as sort of advocates and build that sort of coalition of the willing within the community. I agree the reticence with sharing has reduced, but it's still there. And I'm not advocating for keeping our eyes off the prize in terms of data security and privacy, but I'm probably more in the, and this is a personal view, the opt-out camp. I would rather see data shared by default unless people have a very strong view to the counter, in which case, of course, we respect that.
That's made a big difference on the ground already.
Yeah.
That change from opt-in to opt-out has made a very big difference in uptake and trust as well, and information sharing. So I've seen that in the last few years.
Yeah. And coming back to your comment earlier, Karen, around the role of the clinician, if as clinicians we're able to share with people what's happening to their data and why we're sharing it and why we're communicating with people and exactly what might be shared, as a clinical psychologist, of course, people might not the exact details of everything we discuss to be shared, but to discuss the general care progression and what we're working on can be really, really helpful. So something that's come up this morning and through a couple of different questions is looking at equity and how blended care can be used to improve equity, but where barriers might exist for particular groups as well. And so a couple of questions. So is technology a second best option for already disadvantaged communities? And also, how can we better tailor and personalise care? I've been having a few discussions this morning around culturally and linguistically diverse groups, First Nations communities, and how a lot of our tools might not be appropriate or designed, but how blended care might be able to help in that space. Maybe Mark, I'll go to you first.
The toughest question,
Yeah.
I think, so far. This is quite imperative to get right, particularly for at-risk and disadvantaged groups. So, like in other areas of healthcare, typically people, First Nations communities have had worse health outcomes. I think that's also true in mental health, and regional and rural communities as well have had worse health outcomes. So digital technologies can have a really important role in reaching when there's an accessibility issue, if there's an uneven distribution of the health workforce. For First Nations people, it's so important just to listen to what works best with those communities and to go through a co-design process with them to ensure that the services are culturally safe and appropriate to be delivered.
Yeah, great. Emily, interested in your thoughts?
I think, the avenue in terms of adaptation, I think I just want to say at the outset, I think that digital has an incredibly important role to play, but it certainly is not fit. It's not going to work for everyone as well. So yes, we do need to adapt resources and ensure that we do co-design with particular groups, and particularly those who are experiencing increased levels of disadvantage. But I think there is also an acknowledgement that there are people for whom digital is simply not an option because there isn't the infrastructure that is required, for example, or it's just not, it may not be culturally appropriate and safe. But I do see it as an avenue for enhancing equity by hopefully, enabling some of the resources that might otherwise have been spent or utilised in helping those who can access digital safely and with benefit and so on, can then be redirected to those who need to access services in a different, more tailored, perhaps more intensive way. So I feel like there's a trade-off there in terms of that sort of population benefit with digital at a global level, and there will always be some that will need a different mode of contact, and we really need to ensure that we continue to support that.
Yeah, and thinking about that triage process, matching people to the right level of care. I'm interested in your thoughts, Karen, on increasing equity.
Well, I think if digital is used to enhance a therapeutic relationship rather than replace it, then we are all better off in the sense that the system is more efficient, and hopefully then there's extra funding available to provide more specific services in places where they don't have access, or to groups that don't have access, because there's no one size fits all. So if we can do the best with the finite resources that we have, then maybe it's a win-win.
Yeah, no, and I think That's a really useful comment around, how do we direct resources? And for the things that we do have really good evidence for, anxiety treatment's a really good one. We have really good evidence-based treatments for primary anxiety, and being able to use blended care in that way and reduce clinician time required. But the other thing about the efficiency is that it can actually increase fidelity to evidence-based treatments, keep clinicians on track, and help ensure that people are actually receiving that full dose of care that they need. So I think that's really important as well. I guess thinking about digital evidence-based programs, Jay Court from This Way Up, I'm not sure where they are. Hi, Jay. Has talked about an example of Canberra Head to Health having a really good blended care system, and how could we implement that at scale? What's required to implement good models of care and improve funding for good models of care that work? Yeah.
Are you guys familiar with the Canberra Head to Health model? Because I have a little bit of familiarity. If people need a bit of a... Okay, so, and feel free to jump in. But I think one of the things that makes the Canberra Head to Health model semi-unique is there's a very strong focus on the sort of co-commissioning. It's got public, it's got certainly a multidisciplinary approach, but it's also got public and private sort of partnership associated with it. So there's sort of inter-referral between the public head to health services and services that are provided, say, by the ACT government, along with private providers. And it's a very sort of holistic approach that has been taken. I do think there are some factors that it would be fair to say that are unique in the ACT context that probably lend itself favourably to that. I think we don't have the same workforce challenges here on the same scale as many other areas across Australia. But I think ultimately there are real lessons to be learned, and I think it picks up on, someone else referenced earlier the importance, I think it was in the context of resilience, of learning the lessons of previous. And this is a model that we need to look at, along with other models around the country. But I feel that we really do need to, focus on these things that have worked, see what might be adaptable for different circumstance and give it a go. And, if it works, great. And if it doesn't, let's find a way of measuring it and learning from it so that we don't do it again. So this focus on outcomes, I think, is really important. But sorry, Jay, if that was a horrible bastardisation of the ACT Head to Health model.
I'm going to hand over to our program manager, Ben.
No, I think I agree. I mean, we've just seen Jay's been really instrumental in, I guess, implementing that model, and they've been using This Way Up programs specifically, in that blended care model. It's just a really successful one. I think it would be great to, like you say, look at the outcomes, look at what the cohort, look at the the population, it's how it's working, and how we could potentially use that throughout the country. Because not only with Head to Health but with all services, we see wait lists and real challenges with people waiting for those services. So we have these kind of interventions that can certainly help on that pathway.
Karen and Mark, are there any other thoughts on implementation at scale?
I'm not familiar with that model specifically, but typically what you want to look at is, we've touched on workforce already, the upskilling of the whole workforce, providing resources for consumers around and information around the pathways. That does sound like it's a collaborative commissioning type model, which several of the state governments are moving in that direction, with in New South Wales, say, with their local health districts, working closely with the local PHNs as well to redesign care and to think about care in an integrated way along the community to hospital and back to the community. Again, Queensland's also moving in that direction. I think there's phenomenal potential in collaborative commissioning.
Karen, sorry, Emily.
I was just going to add one more thing to that. I think it also picks up on the 25-year investment comment that was made earlier. So I don't, it's not 25 years, but I think to the extent that we can co-commission and leverage those sort of shared goals at a particular point in time, it does make it somewhat harder for people to, absent themselves from a previous model without giving something enough time to sort of work. Because I think the other thing is that we do have that tendency, often linked with, cycles of government and so on, where, there might be investment, very well-intentioned, good model, but it just hasn't been given enough time to develop and mature, and we just start to see the runs on the ground, and we get in the habit of sort of pulling up stumps and off to do something else. So, not only does it leverage resources better, and that link, I think, with the acute system as well. wherever we are is really important. But I think it also gives it a, let's just say, I think it's protective to the model as well.
Karen, any thoughts from you?
I have many thoughts. I'm not sure which ones I'm allowed to share, really. I'm a big believer in the headspace model for young people, and I think, from what I understand, which is not a lot, the head to health is maybe something similar for adults. I could be wrong. Sorry, but again, I feel like we're already out there. We're already doing this work in community, and I feel like supporting GPs to access the This Way Up services, to have collaborative care within the local community, to enhance the care and consumer workforce within the general practices that are already there and are struggling with funding.
Yeah.
Maybe. I don't know.
At least one solution.
Yeah.
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 Just in the final few minutes, got time for a question from the floor?
Something that I hear a lot of in the suicide prevention sector from organisations who are delivering suicide prevention services is the real fear of digital services and digital interventions replacing in-person, face-to-face services. And as someone with lived experience of suicidality myself, I have my own apprehensions, but then I really liked what you said around enhancing the therapeutic relationship. I thought that was very nice, and it was really great language to hear. And so my question is, if you had some key messaging that we could tell the sector or other services that are worried that digital services are going to take over the world and completely erase the work of clinicians in direct service provision, what would maybe a couple of points be?
Great question. Mark, maybe brief thoughts from each of you. So Mark, what would you think on that?
I think it's those are very at-risk individuals as well, in very vulnerable circumstances. So I think you need to tread carefully around how you might deploy new technologies in that type of context, and providing a lot of reassurance information, letting people know that they can just contact a human being as well when they need to, if they feel like the personal circumstances or symptoms deteriorate rapidly, as well, to have somebody that they can reach out to, I think is really, really important.
Karen?
I share your fear in some ways, and I hope that we can always make sure that there is a human available for care in all circumstances. And I guess the corollary of that is, I think of one of my goddaughters who's very unwell, and who said to me, I wish there was an AI, lifeline kind of thing, because sometimes humans get it wrong. So it is, complex problems need complex solutions. I think it's very difficult, but yeah, I would share your desire to make sure that there are humans available in as much situations as possible. Absolutely.
Thanks, Karen. And Emily, any final thoughts from you?
I've got to concur with my colleagues here, and also thank you for sharing your experience. I do think the view of digital as an enhancement is key in this space, and there will be some areas, I'm sure, that where that enhancement may be greater, or there may be greater benefit, and I think we do again need to continue to look at the very rapidly evolving evidence base in this space, but yeah, it's as an enhancement, and I do love the idea of if you need to speak to a person, that there is someone available. And that's what those crisis lines, I guess, are for, in that very acute need. But yeah, it's tricky.
Just like to add one other general point. I think we often forget that the health sector has been incredibly good at adopting very sophisticated and complex technologies in a variety of different ways, in very high risk settings. So we can do this as healthcare. We've done this many different ways across many different specialties and disciplines. So we are well positioned to be able to do that. It's about leveraging the capabilities that we have, but remembering that there are human beings involved as well, and it's really important to manage the change for all parties involved.
Yeah. Wonderful, thanks Mark. That's a really nice hopeful message to finish on. I'm conscious of the time, so please join me in thanking Mark, Karen and Emily for a great discussion.